Gallagher and Dr. Simperman, and we're here to teach you about how cholesterol is not a dirty word and to expose the myths surrounding cholesterol and cardiovascular disease. Thanks for joining us. So here we are at the Standard Process packaging plant in Palmyra, Wisconsin. And we had the fortunate experience of being able to go to the farm and then see the products that they grow on the farm actually become concentrated whole food supplements, which is the basis of a lot of the prescribed nutritional support we use in our office today.
And as always, the information presented in this program is not intended to diagnose, treat, cure, or prevent any disease, illness, or health condition. And the statements presented in this program have not been evaluated by the FDA, and you should always consult with a licensed healthcare professional before beginning any type of treatment. So let's talk about the history of cholesterol, since that's our topic here today. And this was first identified in a solid form in gallstones way back in 1769. And then again in 1815, it was given a name, cholesterol. Now in 1964, these two gentlemen shared the Nobel Prize in Physiology and Medicine for their discoveries concerning the mechanism and regulation of cholesterol and fatty acid metabolism. So the basics of cholesterol, molecular formula, for anyone that's interested, is up there, C27H46O. It's derived from ancient Greek, chole, which refers to bile, and steros, which is a solid, and this is followed by the chemical suffix, which is OL, and this stands for an alcohol, which is an organic molecule. It's the principal sterol, which is a modified steroid. It's synthesized by all animals, and it's a lipid molecule. And it's made by all animal cells because it's an essential structural component of animal cell membranes, and it's vital to life.
So what are the functions of cholesterol? So there are many basic functions of cholesterol, and one of the most important ones is that we need to know our body. It produces cholesterol by almost every single cell. Cholesterol in cell membranes makes the cell sort of waterproof so that there can be a different chemistry on the inside of our cells and then on the outside of our cells. Vitamin D is a precursor, cholesterol is a precursor to vitamin D, which is formed by the action of ultraviolet UVB light, sunlight, on our cholesterol in our skin, and then it converts to the vitamin D. So if we're on cholesterol lowering medication, the chances of us having this vitamin D conversion are very low. So what about bile? So bile or bile salts are needed for digestion of fats, and they are made from cholesterol. Remember the slide before where we said cholo is bile, means bile in Greek. So that's very important. It also is needed to make many important hormones, including hormones that regulate mineral metabolism, blood sugar, that help us deal with stress, sex hormones such as testosterone, estrogen, and progesterone, anti-inflammatory hormone. It helps us to repair wounds, including tears and irritations in the arteries. It's nature's repair substance. It helps with the production and utilization of serotonin, protects us against depression, the body's feel-good chemical, serotonin. is a powerful antioxidant that fights and protects against free radicals and therefore against cancer. And cholesterol, especially the LDL type, so-called bad, helps us fight infection. So we need to know that cholesterol is vital for our body and also for nerve and brain function.
So here you can see, and we're going to reiterate that point, that first and foremost, cholesterol is a vital component of every cell membrane on Earth. In other words, there's no life on Earth that can live without cholesterol. And that in itself should tell you that cholesterol cannot be evil. In fact, it's one of our best friends. We would not be here without it. And lowering cholesterol too much can lead to many adverse health conditions. So cholesterol is also, as Dr. Gallagher mentioned, a precursor to all the steroid hormones. You cannot make estrogen, testosterone, cortisone, and a host of other vital hormones without cholesterol.
So here we go in our biochemistry, this beautiful molecule of cholesterol, our ever-needing essential molecule of life. And it is only one molecule. It's not all those different things that you see on your lab test. It has only one single molecular structure. It does not come in different forms. This is what it looks like. Just remember that it has one shape. It is one molecule, and we cannot stress this idea enough. So we're going to see why we have those different so-called cholesterols, but we really only have one. And we're going to talk about an addition to this molecule called a lipoprotein.
So how is cholesterol made? Where is it produced in your body? Well, only about 20% of the cholesterol in your bloodstream comes from the food that you eat. That's not very much, considering that 80% of it is produced in the body, and this primarily occurs in your liver. Now, typically, we'll take an example of a 150-pound male is going to make about 1 gram of cholesterol per day. The total body content of cholesterol is going to be about 35 grams. And this is primarily located within the membranes of all the cells of the body. So you can see how prevalent it is in the cells of your body, okay? The typical US dietary intake of cholesterol is somewhere in the neighborhood of 200 to 300 milligrams. So cholesterol intake in your food has little, if any, effect at all on your blood cholesterol or your total body cholesterol.
Okay, so when we talk about the different types of cholesterol, they are really talking about the different types of the lipoproteins. Like I mentioned before, that nice single molecule of cholesterol is just it, just cholesterol. The lipoproteins are what differ in structure. Even then, they do not really differ all that much. The main difference between the types is their density. So the density changes depending on how much of their makeup is what we call triglycerides, which is a fatty acid.
So all cholesterol is the same. The only difference is the lipoprotein that carries the cholesterol around through your body. So thus, we get these different classifications of lipoproteins. Now, the HDL is a high density lipoprotein, and this contains a low amount of triglycerides. The IDLP is an intermediate density lipoprotein, and this contains a medium amount of triglycerides. The low density lipoprotein, or LDLP, contains a medium amount of triglycerides, and the VLDLP is a very low density lipoprotein that contains a high amount of triglycerides. And then we have your chylomicrons, and these are similar to the VLDL. They contain a high amount of triglycerides, and they come from the intestines, so they have a different name.
So again, cholesterol classifications. The cholesterol that comes along with the lipoprotein is all the same, but they are labeled differently depending on which particle is riding with it. So here's cholesterol, and it has a rider, a little side cart. Okay, so additionally, you get more classifications of cholesterol, even though they are exactly the same molecule throughout, except we changed the lipoprotein, the carrier. So all cholesterol, again, is the same. We like to stress that. And that's the big misconception when we look at lab work. So HDL-C, that's a cholesterol that rides with HDL. IDL-C rides with IDL. LDL-C, cholesterol that rides with LDL. And VLDL-C is a cholesterol that rides with VDL. So here we go.
So let's try to clarify this and try to make it simple. So you really need to look at this diagram, and I'm going to explain it to you. So first thing we want to look at is the chylomicrons and the VLDL. Now, both of these particles primarily transport triglycerides to the cells. That's their main role, and that's why they are mainly made up of triglycerides. Now, your cells need energy to live, and fat is one of those forms of energy. Cholesterol just happens to come along for the ride in case it's needed elsewhere down the particle's pathway. Chylomicrons and VLDL are pretty much the same thing. The difference is that the chylomicrons come from your intestines. They involve the transport of fat from your food. The VLDL is the lipoprotein that comes from your liver to deliver fat from storage that's stored in your liver. They both do the same thing, but they start out in different places and have different sources of fat. Now, once the chylomicrons drop off the fat to cells, they go back to the liver. Their job is done. VLDL, on the other hand, drops off the fat and turns into IDL because it has less triglyceride content. Its density rises just a little bit. But remember, the cholesterol is still on board and hasn't gone anywhere. So now let's look at the IDL and the LDL. IDL doesn't really play a major role in all this, but it's an intermediary step. Along with LDL, it has also been claimed to play a part in heart disease. So we want to address it. It either goes back home to the liver or it undergoes more lipolysis to drop off the triglycerides. When it gives up more triglycerides is when we finally see LDL arrive. LDL has more cholesterol content than all the other lipoproteins before it. Here we see the role of lipoproteins change focus a little bit. The IDL, LDL will still be dropping off triglycerides, but LDL also has a role of taking cholesterol to where it needs to go. LDL is the particle that will purposefully deliver cholesterol to the cells. Now, this is a vital process for your body to go through, so it's important to understand. If LDL does not drop off cholesterol to the cells that need it, you would literally fall apart. It drops off cholesterol to be used in the stabilization of membranes, the formation of hormones, which we talked about before. And once it drops off its triglycerides and cholesterol, its job is finished and it goes back to the liver. And this is the summary of the delivery part of the lipoprotein cholesterol life. Now this is more complex, but this is pretty much simplifying it. So you now have an understanding of how your body gets fat for energy and cholesterol for repair. What did I just say? Oh, repair. We're going to talk a little bit about that. And that's something that we're going to get to here in a minute. That includes cells and tissues. What does it repair? It includes cells and tissues that are inflamed, harmed, or in need of repair. So if you have any tissues or cell membranes that are damaged from free radicals or oxidation, those need to be repaired, and cholesterol is what does that. But right now, let's talk about the HDL, because this is different than the other forms of lipoproteins. The HDL is different because it leaves the liver to go pick up cholesterol rather than drop it off. The cells use cholesterol for many things, but that doesn't necessarily mean that it all gets used up completely. So your body has the perfect pathway to take care of that. Reverse cholesterol transport, and that's done through the HDL. This lipoprotein will come and pick up the cholesterol when the cell's done with it and bring it back to the liver. HDL is always referred to as the good cholesterol. It clears cholesterol from the arteries, and it even has an anti-inflammatory effects. But remember, HDL is only a transporter. Cholesterol is still cholesterol. It's now just in a different boat than it was before. Riding with the high density lipoprotein, it's on its way home to the liver after a long voyage. So HDL is always referred to as good, but all the others are also good because they're essential to delivering fat and phospholipids to your cell. Each particle plays a vital role, so we should not automatically label the LDL as being the bad guy. We have to look at why our body has it in the first place. So I hope that cleared that up a little bit. But now you're probably wondering, why does cholesterol build up in the arteries? Well, when I mentioned repair earlier, one of those places that frequently may need repair is in the wall of your arteries. If you have inflammation that's damaged the artery walls or other tissues through things like inflammatory response or oxidative stresses, cholesterol will come to ease the pain and actually start to repair that tissue, because that's what it does. It can repair those fatty cell membranes or the lesions on the inside of arterial walls. Okay, it just might not always work because sometimes there's so much inflammation going on that the cholesterol builds up and even gets oxidized, and it can start doing other things like accumulating and blocking the flow of blood. But cholesterol really here was not the problem. It was trying to put out the fire. The problem really is the inflammation. So we have to remember that, and we can't emphasize that enough. Okay, so that being said, cholesterol in your blood isn't necessarily bad. It can be a really good thing if fat is your main source of energy. The fat gets delivered with the VLDL and the LDL, and the cholesterol just goes along for the ride.
So here's food for thought. Truth passes through 3 phases. First, it is ridiculed. Second, it is fiercely and violently opposed. And third, it becomes self-evident. Myths and truths. So
what about this? this might leave you scratching your head and wondering. In 1984, the normal cholesterol value was 330. 10 years later, 1994, it was 200. And now in 2020, it's less than 200. And I'm wondering, how come? Why? We already know that it's vital and it's essential to life. So why would we need less of it?
So back to myths and truths. So here's a myth. People with high cholesterol are more prone to heart attacks. Wow. Okay, so here's the truth. Young and middle-aged men with cholesterol levels over 300 are slightly more at risk for heart attacks. Those who have cholesterol levels just below 300 are at no greater risk than those whose cholesterol is very low. For elderly men and for women of all ages, high cholesterol is associated with a longer lifespan. Who doesn't want to live longer, healthier and longer? So here's another myth, and we sort of debunked that just before. Cholesterol and saturated fat clog arteries. There is very little cholesterol or saturated fat in the arterial plaques or clogs. Most of the material is a calcium deposit akin to lime, and most of the fatty acids are unsaturated because remember they change their chemical composition because of inflammation in the blood vessel. So here's another myth. Eating saturated fat, which is things like fish and eggs and meat and coconut oil and cholesterol-rich foods will cause cholesterol levels to rise and make people more susceptible to heart disease. There are many, many studies that show no relationship between diet and cholesterol. There is no evidence that saturated fat and cholesterol-rich food contribute to heart disease. As Americans have cut back on saturated fat and cholesterol-rich foods, rates of heart disease have gone up, not down. So that's got to tell you something. So have cholesterol-lowering drugs saved many lives? There's lots of studies that tell otherwise, but in 2 recent trials involving over 10,000 subjects, cholesterol lowering did not result in any improvement in outcome. So what about countries that have high consumption of animal fat and cholesterol? Do they have higher rates of heart disease? There are many exceptions to this observation, such as France and Spain. Furthermore, an association, which is really called a risk factor, is not the same as a cause of a problem or a disease. In wealthy countries where people ate a lot of animal foods, many other factors exist that can contribute to heart disease.
So, since we're talking about heart disease or cardiovascular disease, we can see that this is a very costly problem here. With nearly 1/2, this is about 48% of the United States population having some sort of cardiovascular disease, the costs of this are mounting. Currently, $555 billion per year is spent on the treatment of cardiovascular disease, and by 2035, that amount is projected to increase to $1.1 trillion. Now, the truth about cardiovascular disease is really that cholesterol does not equal heart disease. We mentioned this before a couple of times, and we're going to keep repeating it. The important thing you need to know is that inflammation is what precipitates heart and cardiovascular disease.
So there are 10 top factors contributing to cardiovascular disease, which the number one, as we've stressed already, is chronic inflammation, which can come from a multitude of places, including your diet, stress, smoking, people who have insulin resistance, which is the inability to get insulin into your cell because of inflammation along the cell membrane, and diabetes are at a 250% higher risk of the cardiovascular diseases. So if we're exposed to environmental and chemical toxins, that increases our risk. Chronic endothelial infections, that's infections in the blood vessels, which we talked about before and how the body responds to that. If we are missing our gallbladder, we cannot break down fat like we should. If we have a fatty liver, our livers aren't functioning properly to help make bile to break down fats. If we're overweight, if we're obese, that is a chronic inflammatory problem, and that's going to contribute to cardiovascular disease. And of course, a sedentary lifestyle will also increase inflammation and lead to cardiovascular disease. So that's a lot of things that we know that can contribute. If we have a lot of stress, we're also going to deplete many of our nutrients, and that's going to cause a problem. If we have mineral deficiencies in our diet from magnesium, copper, vanadium, these all have been linked to heart disease. If we're eating trans fats, those and unsaturated fats, those are going to contribute to heart disease. So there's many things that are contributing to heart disease, not just eating foods that have cholesterol in them.
So the LDL is irrelevant, and the LDL cholesterol does not cause cardiovascular disease. And this comes from a comprehensive review of current literature in the Review of Clinical Pharmacology, and that was in October of 2018. And I really believe that Dr. Rodney Hayward, who is a professor of internal medicine at the University of Michigan Medical School, sums it up quite well. And I'm quoting him. Current evidence supports ignoring LDL cholesterol altogether. It's almost impossible to find someone who believes strongly in statins who does not get a lot of money from the industry.
So inflammation, again, causes cardiovascular disease. And here's some information from the journal Clinical Chemistry. And recent evidence has shown that inflammation plays a pivotal role in the inception and progression of atherosclerosis, and population studies have demonstrated a strong and independent association between baseline concentrations of inflammatory biomarkers and future coronary events. So this was from, again, Clinical Chemistry, and what they were looking at are tests called C-reactive protein, and there's a cardiac and a high sensitivity. And those are some of the things we're going to talk about as far as laboratory testing and biomarkers, which are markers that will show us things that are going on in our body. Especially, we're going to talk about all the inflammatory biomarkers that will help us to see if we have a future prognosis or diagnosis of a coronary event. So atherogenesis, which again, there's some information about this from the Mayo Clinic and the Journal of Histopathology. It says it is no longer considered a disorder of lipid accumulation, but a disease process characterized by a dynamic interaction between the endothelial, which is the artery vessel linings, dysfunction, subendothelial below the vessel, inflammation, and wound healing. That's that wound healing again. It's a wound healing response to the vascular smooth muscle cell. So also the oxidation of the LDL lipoprotein, right, the low density. So oxidation means it's broken down and produces free radicals, triggers recruitment of macrophages, which are white blood cells, into the arterial wall. Okay, so here's this wound healing, inflammation, a little bit of cuts in that artery wall. Okay, and if you have these oxidative, stressed out lipoproteins, then they accumulate this type of cholesterol on the wall, which turns into, via the white blood cell, something called a foam cell, which can then form plaque with calcium. So those are the things that we want to really let us know, that this stems from some sort of dysfunction, inflammation, infection in the walls of our blood vessels, which contribute to buildup of white blood cells, cholesterol, which forms plaque. Okay, so it's not because you ate too much cholesterol.
So statins are big business. This is some data from Business Week, and it's back in 2008. But back then, Business Week reported that these were the best-selling drugs in history, taken by 13 million Americans and 12 million others across the world, generating some $27.8 billion in sales. And this was back in 2006. Now, in the Journal of the American Medical Association, there was an editorial back in October of 2014. And in this article, they estimated that the total sales of statins may approach $1 trillion worldwide by 2020. These are the most commercially successful drugs in the history. Lipitor, which was the first one, which everybody's familiar with, had sales exceeding $120 billion between 1996 and 2011. And this is just, when you look at these figures, it's just staggering, the amount of money that the pharmaceutical industry is making from these types of medications.
So have statins actually helped? So this is from our own CDC, and they said between 1997 and 2007, no major changes were apparent in the age-adjusted percent of coronary heart disease, stroke, or other heart conditions. So this was right from their National Center for Health Statistics, Division of Health Interview Statistics, data from the National Health Interview Survey compiled by personnel in the Division of Diabetes Translation, National Center for Chronic Disease Prevention and Health Promotion, and this is from our CDC. So have they helped? Apparently this is the last information we have about it. So not sure if they've helped. I don't think from this, doesn't seem like they've changed much.
So in addition to being of questionable value, we know for certain that there's a laundry list of well-documented, undesirable side effects associated with the use of these types of medications. Number one would be diabetes. Now, the Women's Health Initiative reported a 48% increase in diabetes in postmenopausal women who were using statins. And what about cancer? Well, the Journal of Current Oncology in 2008 showed that there was a strong association between statin use and higher cancer risks. Now, again, in regards to cancer and their relationship to statin use. In every study that they did with rodents to date, statins have caused cancer. Now, most human trials are not carried out long enough to detect any increase in cancer rates. But in another trial, breast cancer rates of those taking a statin were 1,500% higher than those of the controls. So what about nerve and muscle damage? Well, weakness and muscle wasting. This is one of the most common side effects of statin drugs. And this occurs in as many as 1 in 3 users. Muscle aches and pains, back pain, heel pain, weakness, and slurring of speech can result from statin interference with the production of coenzyme Q10, and this is needed for the muscles to function. All right, we also know that in 2002, the Journal of Neurology looked at long-term exposure to statins and found that it may substantially increase the risk of polyneuropathy. And then there's depression and suicide. And the Journal of Psychiatric Times reported that studies have shown that lowering cholesterol disrupts serotonin, which could lead to depression and suicide. Now we have dementia and memory loss. MedWatch data from 1997 to 2007 revealed that 662 spontaneous adverse events of cognitive impairment were associated with the use of statin medication. Now, many patients using statins have reported memory loss, brain fog, including total global amnesia. And this would be like an episode of complete memory loss. And the implications for pilots and those driving cars and trucks are profound. Think about that. If this happened to you while you were driving, that could be catastrophic. And what about heart failure? Rates of heart failure have doubled since the advent of statin drugs. The heart is a muscle that depends on a plentiful supply of CoQ10. And we just pointed out earlier that statins interfere with the production of coenzyme Q10, okay? So we also know that in the journal Expert Review of Clinical Pharmacology, back in February of 2015, they discussed the slow process of how statin drugs cause the demise of heart health and contribute to heart failure. So we can see that these medications, despite the fact that they're widely prescribed and the most lucrative medications that the pharmaceutical industry has, they are of questionable value and they do have many adverse risks and side effects associated with their use.
So primary mechanisms for the negative effects of these statins. So what happens? And we talked about the cholesterol reduction. So when we reduce cholesterol, we're going to reduce the ability of our body to make hormones, not only adrenal hormones, sex hormones, anti-inflammatory hormones. We're going to have cognitive impairment. If we use these medications that cut off the diachol inhibition, which will then produce more diabetes, neuropeptide dysregulation, it'll alter protein synthesis so we can't repair, and much more. Again, we're going to talk about the CoQ10 reduction. So if we reduce CoQ10, we're going to reduce cell energy production, we're going to damage our cell, we're going to have heart failure and congestive heart failure. And also, we change or mutate our mitochondria, our powerhouse of our cell, the energy producer of our cell. We're going to mutate its DNA with these statin drugs. We're going to cause mitochondrial damage, which is going to cause mitochondrial failure, which in turn will cause organ failure of certain organs like the heart, the pancreas, muscle, and nerve damage at the least, if not full organ failure. So what can we do? How do we manage, or what labs do we use to help decide what our cardio risks might be? And blood analysis for the cardiovascular disease can give us lots of information as to our risk factors, our prognosis, if we're taking medication. It can show us if it's helping or not. So these are some of the lab tests that I recommend for patients, and I hope that you discuss this with your PCP, or of course you can discuss it with either Dr. Simperman or myself if you choose to decide to come and be part of our practice. But anyway, I'm going to review each one of these. So the cardiac C-reactive protein, we had a slide about that earlier. That's a very, very big inflammatory marker. It's a biomarker for inflammation. When we have something going on in our bodies, it's going to trigger the liver to make this inflammatory cytokine. And we've heard that term a lot lately. We don't want inflammatory cytokines because it's dangerous, and things that can cause inflammation and increase this biomarker would be a sedentary lifestyle, some sort of infection, obesity, diabetes, smoking, allergies, and autoimmune diseases, as well as, didn't mention a sedentary lifestyle? If I did, sedentary lifestyle, I can say that about 4 times. So that's the big one. So lipoprotein associated phospholipase A2, well, that's a lot to say, but it's abbreviated LPPLA2, and this is a platelet activator. So this is a very good prognostic marker for coronary events for the future for people with diabetes and metabolic syndrome. So we don't want this showing up. What about homocysteine? You might have heard of that, but maybe your doctor never wants to do this. This is an extremely important biomarker. It tells us the health of that heart muscle. It tells us whether we can actually use B12 and folate. People have genetic SNPs in this area and they can't. And if that's the case, they're going to build up inflammation in their body. It also could be an indicator of not only cardiovascular disease, but neurodegeneration, endocrine issues, and it's going to show us that we have increased inflammation in the blood vessels. So if your homocysteine levels are up, you can have a lot of inflammation in those blood vessels, which again, the body's gonna react to in a wound healing type situation. So let's see, let's talk about fibrinogen. That's coagulating factor. It's made in the liver when we have tissue and vascular injury, and it's a really good risk factor to check for cardiovascular disease and plaque formation because it'll institute the formation of plaque in the vessel walls. Fasting insulin. This will show us whether we have insulin resistance, meaning we make insulin, but it can't get into the cell. The lock and key mechanism is wrong. Something happened, whether there's inflammation or it was genetically dysfunctioned or there's nutritional deficiencies. Something happened so our bodies cannot get that insulin in, and this is a precursor to many people having diabetes. So this is a really good marker. And then we have just the plain old fasting triglycerides, which are an independent risk factor, not included, but will be included in your basic lipid panel. But if we just get fasting triglycerides, that's just going to tell us how we're doing with that risk factor for cardiovascular disease if the fasting triglycerides are up very high. So when we assess cardiovascular disease in our office, one of the first things we do is we want to make sure we do that correct blood laboratory analysis. If you're not going to come to our office for this risk assessment, then we ask that you consult with a clinical nutritionist or national healthcare provider to assess risk factors and provide a specific guided health improvement program. Most traditional medical offices really don't work with clinical nutrition to help with heart disease improvement. So we will work with you in a doctor supervised basic heart disease support nutritional program to help you with your problems as associated with some laboratory findings. If you are on a statin medication and choose not to go off, we will support the side effects of those statin medications with nutritional supplement programs. We'll prescribe an anti-inflammatory diet. We will suggest that you do regularly scheduled exercise and not just movement, which is just counting steps or gardening or mowing your grass, but we want regularly scheduled riding your bike, running, aerobic type exercise, weightlifting, things that are regularly scheduled, not just moving around and counting that as exercise. So we want to say thank you for listening. We know it was a lot of information. You can listen to us again through this link. If you are very interested, whether you're an existing patient of ours or you would like to become a patient, a new patient, and you want to have a complimentary cardiovascular risk assessment appointment, we will do that at no cost to you because of your interest in listening to our seminar today. We will review your lab tests. We will work with you with a dietary analysis and give you some recommendations and design a individual nutritional heart health improvement program, which is a one-on-one individual program. These are available, valid from the 16th of September through October 16th. So if you make an appointment anytime in that period of time, we will honor this. And this is for both our new and existing patients. And you need to give us a call for a special appointment time. And we want to say again, thank you very much for joining us.